Hello and welcome to another series in the People Living with HIV Leaders Now podcast series. For those who may not know, the Global Network of People Living with HIV is organizing a series of conversations with leaders, past, present, in the future leaders, to think through what would be needed to keep the people living with HIV leadership going, to appreciate the leadership that has gotten us this far, and to reflect on the current moments we are in so that we are able to be impactful in our advocacy, in our representation, and in the shaping of the policies, programs, plans, and resources towards ensuring the global goals of the HIV response are realized. Today, I'm joined by a friend, a colleague, Andy Seale. I don't know if Andy needs any introduction. This is one of the allies we have, person living with HIV himself. And this is why we are so excited to be sitting in Rwanda post the conference. And we will do a little bit of a reflection of the conference. But also, I would like Andy to introduce himself and tell us a little bit about who he is, his journey in the industry. But Andy and I today are going to sort of sit and have a conversation looking back at the leadership of people living with HIV from a decade or so ago to where we are at now as we look into the future to inspire what would be needed to take us forward. Welcome, Andy.
Thank you, Florence. It's great to be here.
So tell us a little bit more about Andy and the movement and the work.
Wow. So actually, it's more than a decade. So I guess I've been involved since the 90s. So I was with a partner in the 90s who was living with HIV. So I was involved in local community groups in London. But my job at the time was harm reduction. So I did work in health and I did work in a linked area, but I wasn't working specifically on HIV. And then, to cut a long story short, I moved into international work, initially to work on malaria.
Okay.
But by this time, I discovered that I was also living with HIV. And I waited a little while before I moved into HIV myself because I wanted to make sure that personally I was ready and in a good place to be able to kind of like work professionally, dispassionately almost, with communities, with colleagues on HIV. So I started in UNAIDS around 2002. And one of my formative moments in this movement was the 2003 People Living with HIV conference in Kampala, Uganda, which blew my mind. It was incredible. I'd never been in that kind of environment before with so many diverse, crazy people living with HIV from all around the world.
Yeah.
And I made lifelong friends and amazing connections. And even now I'm getting goosebumps thinking about, that week. It was incredible. I learned so much. I learned humility. I realized that I'm a bit of a background guy. I'm in institutions, so I'm not out there doing the frontline activism, but I'm supporting that and I'm helping to bring that activism into policy, into programmatic work, and into really the priorities of the organizations that support a lot of the critical work that's needed. So that meeting in particular was formative for me. And then soon after that, I got together with other colleagues who are working in the UN system, and we recognized that wherever you're living and working, and you're living with HIV, it's likely that you might be facing challenges.
Yes.
Of course, we were privileged compared to most, but nevertheless, we were still facing challenges as staff of the UN system in terms of making sure our treatment was reimbursed to us, making sure that we could travel appropriately.
Yeah.
At the time, we couldn't enter the US because of the travel restrictions, for example, and of course, a lot of meetings were being held in the US and other places. So we did a lot of work both to support ourselves as a community around things like health insurance, etc., the rights of same-sex partners. We touched on a whole range of different issues, but we also worked with communities around things like travel restrictions, around things like, treatment access, obviously. And again, through that work, through UN Plus and also working at UNAIDS at the time, I think I was at 2 or 3 TAC congresses in South Africa.
Oh, wow, yes.
Again, mind-blowing.
Yes.
And I've just had this really privileged, amazing journey. Bit of a background guy, as I say, but I've really appreciated that opportunity to work as a positive person inside the system, if you will, and making the connections with community. And it's just been such such an inspiring and privileged part of what I've been doing for a long time now.
Yeah, and I think I'm inspired by this. I have to admit, Andy, that because you're WHO and you're in the system, and every time, especially as I've grown in the movement, what being with you, like back in the background, every time I'm speaking somewhere and I'm scared, it's your eyes I look out for. And you're always winking at me as if to say, you're doing great, keep going. And I think just to reflect a little bit for particularly most of the people who would like to do the advocacy work but feel like they're timid or they're introverts or feeling like, oh, I can't go and get into a march, because we are diverse.
Yeah.
We all have diverse experiences and qualities.
Yeah.
And some people have this idea that for me to do advocacy or for me to do representation, I only have to be a certain type of person
Right.
and have to do. But you're demonstrating that sometimes with the skill set we've got, you can be the back end person.
Mm-hmm.
And there's a lot of influence there because you're able to influence the policies and the system as the system is making its decision. I don't know if there's any reflection of advice you would, and I think sometimes people feel FOMO,
Mm-hmm.
like, oh, I didn't go to that match,
Right.
or maybe, or like for in my case, I feel like I'm a sellout. I had to sit down with that for a while to understand I bring a different, I bring a different investment, and it
Sure.
may not be me in a t-shirt with the crowd, but there's another investment that I will bring into the advocacy. So how do you navigate this? Sometimes guilt, sometimes feeling like you're not enough. What would you tell particularly someone who's thinking
So
through this?
I think first of all, if you are engaged in the positive movement and you're living with HIV and you're open about your status and you're talking with colleagues or friends, you're already making a difference. So you're already making a difference in terms of, like, speaking comfortably, demonstrating how you can be as a person living with HIV. And then the other thing I would say is activism and advocacy comes in so many shapes and forms. And when we think about power, power is everywhere. So we all have power within, and we have power when we get together. We have power when we're strategic about, the people who are doing that activism and campaigning with the placards and with the disruptions.
Yes.
That's a really important part of this, but it's not the only part.
Yes.
Some of the quiet activism that happens inside institutions, and for this I would say we have many allies.
Yes.
So, my boss, Meg Doherty, she's not living with HIV, but she's an activist, and
Yes.
she's within the system fighting for the all of the ethical things that we want to achieve. She's battling inequalities, trying to get access to as many people as possible. So again, I think it's really about looking at what's available to you. So even if you're just making an influence in your own family and your own community, you're making an impact.
Yeah.
If you're working in an institution that's also working on HIV and you can influence the thinking inside that organization, it's fantastic. If you can make those connections across, and this is where I think it's been just so interesting to me, having you, we all wear many hats. So I can put the HIV positive hat on, I can put the WHO hat on, and then sometimes it beautifully comes together around an opportunity that really requires it.
Yeah.
So we had the Mpox outbreak, a few years ago, and very quickly, communities largely of people living with HIV, and it was largely men living with HIV who were impacted by the global outbreak. They mobilized so quickly because the networks were already in place. We were on the phones. We said, what are we going to do here? And it was people from community groups, from industry, from government, from the UN. And the mobilization was so fast. And my colleagues who work in emergencies have asked us to write this up because they've said, they always talk about community mobilization. They've never seen anything like this. They've never seen anything like it. So I think we've got a lot to be proud of within the very diverse networks that we've built for HIV. And when we work together and constructively, and sometimes we have some little disagreements, and that's fine because they're usually constructive disagreements. When we really get together and we recognize that everybody has a different role to play from a different angle, it's magic. It's fantastic.
It's fantastic. And I like that it's magic. And so I want to take you a little bit back to 2003 and subsequent. And I think the HIV movement has had moments. So we always talk about the Denver Principles in 1983, I think. Yes. And then now you're talking about 2003 because that was the first living conference. And then we've always had these living conferences. At a time like now when everyone is thinking, what's the point of investing in community and community engagement? I think it's difficult. You're saying almost 20 years later, you still feel goosebumps about that meeting that happened. And I think to situate the scenario then, HIV stigma was at its highest. There was no treatment for many people, particularly in Africa, at the time. And even saying you are HIV positive was not an easy thing. So coming into a room and finding so many people, that is huge. And it motivates and makes people alive. We have a colleague in office who was diagnosed in 2023.
Right.
And he studies in Europe, and then we put out a call, and he's in the office, and he said he just walked in and saw all of us and was like, oh, okay, I will leave, because and you would think all these years later there's a bigger picture. So I just wanted to underscore the magic that happens when we come together, and just ask you, what do you think is the argument we can make? Because in a world where there's financial constraints and people are rightfully so feeling the need to prioritize, this doesn't feel like something that you can, whose impact you can measure financially. Oh, people met, they have goosebumps. How do you make a case for the community movement building that is required to carry our work along?
You know, I think part of it links to what we've formally come to know as community systems.
Okay.
So I think we've kind of institutionalized and professionalized our thinking around the community contributions to the response, which I think has been a good thing. So I think, you know, community-led monitoring, community systems, whether it's around demand creation or service delivery and access even, all of those things are critical. And we know that there are some communities that really struggle with access.
Absolutely.
They struggle with adherence, and it's peer support, and it's outreach from people in their own communities that makes a huge difference. So those things we can measure, and we're increasingly getting better at that, particularly when the measurement and the M&E comes from the community itself. But of course, that needs investment. And I think, honestly, one of the best ways to engage donors is by bringing them into scenarios where they can feel the goosebumps themselves, seriously. And then they realize that it goes way beyond what you can put down on numbers on a piece of paper. They see the warmth and the family that has been created between people, and that deep sense of commitment that you only get when you're working really with people in this field who are motivated, because, you know, we're all living with a lifelong condition. We've all been fortunate to most of us have been fortunate to have access to treatment, and so we're living well. And I think many of us, let me speak for myself, we feel as though, you know, we have something to, you know, we have a responsibility to pay a little bit back.
Yes.
You know, because not everybody has been as fortunate as us. So I think, and as I said before, you know, there are plenty of allies who are not living with HIV, but who've also been impacted through friends, through family. So again, it's a broader network. Of course, I do, rightly or wrongly, prioritize in my own mind brothers and sisters who are living with HIV as part of my community. And then, but from there, you very quickly reach into the people who have made fantastic contributions. And
Yeah, and I think when you have that lens, it's difficult. I was doing a personal branding process, and she said, what's your priority? And I said, I would love to democratize leadership, PLHIV leadership, people living with HIV leadership. And she said, but why don't you just make it leadership? And I kept saying no. And, you know, she's from the private sector, and she couldn't understand why I was very specific. And I'm like, other people can do other leaders. I just want to do this. And it's because it's part of you, and so you see it not really as giving back, but we become conscious to the challenges many of us face. I like to also joke about the fact, and I want to ask you how, for many of us, I don't know if when you were tested, you were told if you do this and do that, you have like this number of years to live. Did you get told that?
Similar, yeah.
So subconsciously, I don't know if that happened to you, but I find that mine was 10 years, and if I did the math, it was supposed to be 2016. And so I try to tell people that I'm catching up, because I woke up in 2016 and now there's advancement in treatment. And here I am, when my whole life subconsciously I was doing the 10-year mile. And then now you're like, oh shoot, I don't have this, I don't have that, I didn't set up a pension, I didn't, because I wasn't even meant to be here. And all of us are sort of playing catch up.
Yeah.
But in 2003, I think we know what happened in Denver Principles and the things that brought people together and the ambitions people had. And some of it was this, to make sure we have agency, to make sure people living with HIV can love and live and have quality of life. And 2003 must have been its moment. And now we are sort of in another moment. In it's a significant shift.
Yeah.
We are finding ourselves in a funding constrained environment with a system that is shifting.
Yeah.
Naturally, you would love a system to shift in its own way, but now it's being forced because of financial constraints. So that is sort of playing out differently. What do you think leaders now need to take into consideration for people living with HIV so that we don't lose the aspirations of the moments as they have been building up from 1983 to now? What are those fundamentals that we must make sure we secure?
So within the community, the leaders within the community, or leaders writ large?
At large.
Okay. So I think, first of all, they need to recognize that, I mean, we were speaking earlier, some of the most inspiring people who are living with HIV now were born with HIV. So
Yes.
these are young people.
Yes.
They have different experiences to us. They've not had to, they've gone through, different ways of discovering that they're living with HIV
Yes.
at different times in their lives. And their energy and their insight, it's quite different, I think, to some of us who are a little older. So I think, first of all, appreciate the heterogeneity of people living with HIV. We're very diverse in terms of age, in terms of background and experience, and value that. There's so much tremendous value in that diversity. And so whenever you're convening, try and really convene that as broad a group of perceptions and experiences as possible. And now for the current moment, and it is a crisis, I think there are two things. I think we need to balance activism and urgency, and that real sense of urgency, and really encourage some bolder activism and outreach from all sectors, particularly from within the community. But we also need to be quite thoughtful and strategic and focus on what can we do, what relationships need to be fixed, how can we, our landscape has changed so much now. So a bunch of kind of like really important players are not as present as they used to be.
Yeah.
So does that offer us some opportunities? Can networks of people living with HIV get closer to government and try and build some of those relationships? And often a lot of the really sensitive subjects around HIV are linked to prevention, and they're linked to sexual transmission, they're linked to criminalized populations, they're linked to key populations. And networks of people living with HIV can be a really helpful entry point for access to those other groups, whether it's sex workers groups, gay men's groups, and transgender groups, etc., people who inject drugs. And they can create space where those conversations can take place. So I think that we need to be thoughtful, we need to be strategic about how can we rebuild some of those conversations that are critical yet sensitive, and every country will be different.
Absolutely.
Every country, and we also have to recognize that there's always a disconnect between the legal and policy environment. So yes, in certain countries, certain populations will officially be criminalized in terms of the law, but is that actively being pursued? What barriers does it present to access to HIV? How can we pragmatically make sure that people get their access to healthcare? So of course we want to ensure that the agendas around, addressing human rights are pursued and pursued, aggressively. But for me, I think the first priority is making sure that people who need access to prevention tools, so key populations, adolescent girls and young women, they have access, particularly to PrEP, and we can talk about the new innovations perhaps a bit later. And then obviously treatment access for people living with HIV. And then hopefully increased access to the options that are emerging around treatment as well. So I think it's a moment for us to reflect. There's been a lot of change. We won't understand the impact of these changes for some time. They're taking their time to kind of like really show up. But I think we've got to be alert. We've got to really be communicating often.
Yeah.
And if communities can, as GMP Plus has done, continue to be part of that intelligence gathering
Yeah.
and share where there are stockouts, where there are problems, where services are disrupted, so that we can really focus on the practical, what can we do to get this back to where we need to be. So we're in a moment of crisis, but that's also a moment of opportunity.
Moment of crisis. Oh, I read somewhere, or I've been hearing that said a lot, never waste a good crisis. No, there's no good crisis. Never waste a crisis. You can make good out of a crisis.
Yes.
Maybe I'm mixing two things, but I totally agree with you. And I think for me, it's been, how do we frame? And I think language and narrative change would be critical right now. And as I look at in this scenario of reprioritizing, everyone, we've been engaging with you, you and the team at WHO, and everyone is like, oh, treatment versus, it's sort of becoming a versus kind of this versus that, this person versus this. And I feel like it's why I say we need to frame our work back to the purpose of why anyone does an epidemic control. I mean, an epidemic response.
Yeah.
It's epidemic control, and you have to close the tap on new infections, and you have to end AIDS deaths, and all of these matters are important. And if we frame our work in that way, then it's not a this versus that. This is more important. This is not. Is not. It's all of these things are critical
Right.
to getting us to the desired outcome. So a little bit about your thoughts with the new innovations. And I mean, you've been here a while. You saw ARVs in plates.
Yep.
And different. I didn't see it because ARVs came to Kenya late, and then for us we didn't have to start treatment until later. So post my diagnosis, I think I started treatment another 10 years later.
Yeah.
But I used to watch these videos that would come out of the US and stuff of these platefuls and hear stories about you have to take some medication you have to take with oily food and some medication you have. So it was a whole different life then, and coming into the network and watching people going through body disformations because of treatment and things like that. We've come a long way.
We have.
What is the excitement, and please just also share a little bit about how WHO has helped to further the shift and the movements in the innovations that we are seeing now, and then talk to us a little bit about lenacapavir and the different innovations that we talked about at the conference.
For sure, no, pleasure. So when I was diagnosed, I was quite sick. So I went straight onto treatment because I was past the threshold for treatment start. So I had opportunistic infections, and I had a handful of pills to take every day, including AZT. So it was quite aggressive, but it worked. It worked really quickly for me. And at the time, I think WHO's recommendation was treat at 350 or below. Not even, it could have even been 200 or 250. I forget now in terms of CD4. And that was applied to me when I accessed treatment for the first time in London. So I've watched my own personal journey also evolve in the same way as WHO guidelines. So obviously we've had fantastic innovations. I was on a drug called efavirenz for some time, which was very unpleasant, I should say. It was very, very effective for HIV, but the side effects were considerable. So I was very happy when I had the opportunity to move off that one. But I think we all know the basic milestones for WHO. So it was treat all. I think that came out at around 2015. Yeah, I think so. So that's when we really saw, and we saw some slides this week actually, of how treatment was really starting to pick up. But as soon as treat all was introduced as a policy, and it was rapidly adopted by countries, you see a huge spike upwards in access to treatment. Of course, we had PEPFAR and Global Fund all at the same time. So it was a fantastic kind of like constellation of the stars coming together to create this moment. So treat all was a really important opportunity. And then we've seen obviously more powerful drugs emerging, combinations in one tablet. Dolutegravir, of course, became a very important drug for access in low and middle income countries. So we've seen these fantastic evolutions. Really, they've largely been focused on oral treatment. And of course, the exciting thing over the last few years, which personally I was a little bit dubious about, I have to say, is the evolution of long-acting injectables. I did wonder if long-acting injectables might not be, welcomed by community.
Yeah.
And I learned very quickly to put aside my own biases and listen to community, because my goodness, the interest is there.
Yeah.
So we've heard a lot this week about long-acting lenacapavir as a PrEP tool, as a prevention tool, and the promise from that is also incredible. But also we've heard a lot about long-acting treatments as well.
Yeah.
Some of them match up with the options that are being made available to PrEP,
Yeah.
which is exciting. And I've got friends in Geneva who are already taking injections every couple of months for treatment, never mind prevention. So we're in an exciting time. So it's a paradox again. HIV has been a history of paradoxes, where we have these amazing innovations, but we're in crisis.
Yeah.
But I think these things will balance out. I really do. The energy we've seen at the conference this week has given me a lot of optimism.
Yes.
Yeah, there's a lot of interest.
Yes.
And I think people are looking for simplified ways to administer treatment, to administer prevention, simpler for the individual, which is the most important thing, but also simpler for the health system. So I think we've got some really exciting years ahead.
Me too, and I feel I'm with you on the interest, even with governments, which we had thought they probably will not be interested. But you see, even the excitement with governments. But I think also the movement now, there's just this intentional need to bridge the gap between innovation and access.
Right.
Because usually there's innovation and then it takes a while before
Yes.
people can access the innovation. So I see the intention with everyone, even in the times now, trying to sit and think through how do we make this
Right.
innovation reach all those who need it. And
Yeah.
and there's an appreciation, and you keep mentioning Meg and the colleagues in your office and as allies. And I think for me, it's just a comment and then ask you another thing. But it's been coming into this field right from the country level and walking into, because again, if you exist mostly from the activism side, it's built on the mistrust, right? We don't trust the system, we don't and then when you get into the system and you sit with people who are burning midnight oil at sitting with you trying to figure out, and you see the commitment from people who would not need to do this anyway, but they are sitting and they want to get to the bottom of how do we fix the PMTCT issue?
Right.
Why are we missing the children? And you see the care and the concern, and to be honest, as someone who has engaged right from country level to the global with the system's back end, it's been such an honor to watch allies. I don't even call them allies. I think they're just the most gracious leadership I've seen about people who want to engage with our lives in a different way. So last batch of questions, I promise. So you and I have been talking a lot about the big monster, integrating HIV services into primary healthcare. But we didn't start talking about this. And I think your leadership helped develop some nice guidelines at WHO, which was really exciting for me to see. I just wanted you to talk a little bit about what inspired your interest around looking at integration. I am keen to hear again you demystify what this is for us, and to just reassure us as people living with HIV and communities that it's not evil. It's not the evil, but it's something that we can use as an opportunity to make sure that health services are responsive to our needs as we evolve. Because from our GNP Plus side, hosting the Living Conference last year, this became a running theme by people in the conference that as we are aging, we don't want to go to different health facilities. We would like to have, and especially for women living with HIV whose vulnerability to cervical cancer is 6 times higher, saying if the screening tool is in my HIV service, I would use it. But if you tell me to go elsewhere, I don't have the time. So just to sort of take some time to reflect on what this is for us.
No, thanks, Florence. And I think you've hit the nail on the head. There have been lots of surveys about asking people living with HIV, what are your main health concerns? And so often depending on which group you're talking to, you'll often find that HIV doesn't even appear in the top 10. It could be mental health, it could be physical activity, it could be a bit of extra weight, it could, there are lots of things, cancers, there might be some skin issues. So we shouldn't assume that HIV is the number one health concern of those of us who are living with HIV.
Yeah.
It's often not. So I think that's the number one thing. So I think a lot of the work that we've been thinking through has tried to really put people and individuals at the center of the thinking. So not coming in from a systems point of view, not coming in from a disease specific point of view, but thinking about the individual. A system around these people work optimally so that their holistic health needs and their well-being needs are being met. So there's a number of things that we've realized. So that when we talk about integration, many people have different ideas of what this means. So that we tend to look at the primary healthcare approach, and the primary healthcare approach is very different to primary care services. So a lot of people think that integration is just about combining services. So, let's combine, I don't know, TB and HIV,
yes.
or HIV with
NCD.
Sexual reproductive health, etc. It's way beyond that. So when you look at a primary healthcare approach, which includes multi-sectoral policy and action, as well as primary care services and other types of service delivery with community engagement, you have a much more comprehensive understanding of what's possible. And so we've done a lot of work to look at, what are the strategic opportunities around governance, around political will, around community engagement, and what are some of the operational opportunities for integration. We use a PHC operational framework as a guidance tool for this work. And that could be the health workforce, it could be, logistics, it could be finance. But we try to really look at the whole ecosystem. And we've recognized that when you are deliberate about trying to improve the experience and the health outcomes for individuals, you need to tap on lots of different parts of that ecosystem. And so I've done quite a bit of that, like theory work, if you will, at a global level. But the really nice thing about how this work has evolved is that now we're getting lots of really important case studies and examples being fed back to us from countries. So you and I were in a session yesterday. We heard from South Africa, we heard from Ghana, we heard from Vietnam and a number of other countries. And they're all quite varied, but they've got fantastic examples to share. They might not be 100% transferable to every context, but there's learning there. And and the one thing that I've recognized is that you need to have some champions on this. So you need champions within ministries of health, ideally at political level. But you also need some community champions who are willing to take some of these risks. Sometimes it's stepping into the unknown. Sometimes it's getting out of your comfort zone. But sometimes that pays off. So I think let's keep an eye on this space. We've also heard genuine and understandable concerns that integration is being used to erase or invisibilize, communities who might be marginalized or decriminalized. And I think from a WHO point of view, if integration is not working for the most vulnerable and the most underserved in society, it's not working. So that has to be a starting point. So you need to have stigma and discrimination has to be there. We have to keep an eye on that. Particularly if you're starting to encourage engagement with health workers who are not used to interacting with people living with HIV. There are training needs there. But it's very different today than most people know the basics around U equals U, thank you. And if they don't, it's a very easy message to transmit. And so for healthcare workers, if they're open-minded and if they're following, the ethics that they subscribe to when becoming a healthcare worker, they should realize that there is no risk or super limited risk of any kind of transmission occurring in any intervention in a healthcare setting. And so that, I think, it's a very, very different experience. I mean, I remember 10 years ago when I was living in Johannesburg, that my dentist wouldn't book me in until the last session on a Friday, so that he could disinfect the whole kind of surgery. This is in South Africa. And I think, which is crazy. Dental services have always been challenging for people living with HIV, I should say. But even dental services, I think they've really moved on. They've improved massively. And I think I've noticed, and I think we've seen this in survey data as well, that general levels of understanding and a drop in discrimination has been occurring. But we still need to keep an eye on this. And the fantastic work that GMP Plus does on the stigma index helps make sure that we're alert to where we need to do more work around healthcare worker training and stigma. And some of it's also training within our own communities as well, so that we go into situations with confidence and we're not afraid to do a bit of education if we need to in those moments. It can be tiring, But we also have roles to play in encouraging people that we interact with to feel safe.
Nice. Final. AI has been mentioned as a critical component for the next 5 years. I have outed myself as still being very behind on the matter, but now very, very motivated to go back and at least use my chat GPT at a starting point. But just your thoughts about what opportunities exist for AI and for digital components, both for public health, but also for messaging and addressing some of the social barriers as we go into the future.
I mean, I think it's a fascinating area, and I think AI touches on every aspect of our work. So again, even as individuals, like you say, I mean, I tend to use Chat GPT if I'm faced with with a difficult kind of situation. What should I be considering here? And it gives you some really thoughtful steps, about how to think through, various challenges we might be facing. But no, we're seeing AI really being used thoughtfully in data and digital health. I think also as a training tool. We're increasingly using AI as part of our knowledge management approaches with WHO because we've got so many guidelines. Sometimes we just need to make sure that there's the right tool. So you can put into a kind of like a Chat GPT equivalent, what regimen do I need when this person is presenting with X CD4 and X viral load? And, getting that, really comprehensive, fast response. So, it's, Google search is plus, but with a clinical bias. I mean, some of the work that's happening there is very exciting. And I think, again, also identifying populations who may be at heightened risk and who require, for example, some of the tools like PrEP. Really thoughtful work around analyzing data and trends, even looking at geographical hotspots that might need to be prioritized around prevention work. There's a lot of really exciting work happening. I think some people have felt concerned that maybe AI is going to replace some of the roles that we perform. I don't think that's the case. I think it will enhance the work that we do and hopefully make us a little bit sharper in our decision making. But it's a really exciting space. I've got a couple of colleagues who are really quite expert on this. People, my colleague Cheryl's doing a lot of work around the use of AI within HIV testing approaches. Really exciting work there. And again, my colleague Shona is doing great work on the use of AI with data. I wish I could bring them out now so that they could give you more detail.
Follow them.
But we can perhaps,
Yeah, and I think it's quite interesting, and I think especially for the young people, it would be a critical opportunity, and it's their world, they're thinking, and they will use it, and we will need to humble ourselves and learn. Andy, this has been great. You and I can talk every day, like
we could go on for
we
hours.
could ask 5 more different topical questions, but I'm hoping we can do this again.
Yeah.
Thank you so much. I think in the final question for me, as people who are sitting in the back, how can we be useful to you? How can we also serve you? Because I think half the time you don't get seen, you don't get recognized. Half the time, if you don't even declare your status, many of us don't know who's living with HIV. But I know there's lots of people, and just to share with us how we can, those of us who are sitting on the other end every time, how can we be of service to you?
No, thanks, Florence. And I think, for the moment, WHO is going through quite some changes, as is all of our organizations are facing changes, and many of us are having to reduce staff numbers and cut back on programs. So I think it's really about staying connected through you guys. You're a really important interface for us, and I know we check in regularly. To recognize, what the different institutions internationally do and are capable of. So again, please, if there are colleagues working in communities who, particularly as UNAIDS and WHO go through changes, you have ideas for where there might be something missing from the UN system. Reach out to us through you guys or directly to me at WHO, and we'll just, we'll just try and sit and think through what's possible. It's a big period of change. So if we hear quickly about where things are going wrong, either in terms of relationships that need to be, perhaps had a look at, or there are service disruptions, there are system failures, there are human rights abuses, and there's a real problem around X community and service access. it's our job to be working closely with you. Sometimes as an interlocutor with governments, but not
Yes.
always. Often it's a tripartite
Yeah.
thing. You know, it's
True.
there's often not that us and them. Often, if you find the right people within institutions, you can find the people who are all pulling in the same direction.
Yeah.
So even in the most difficult context, you will find champions.
Yeah.
And you will find champions who are keen to get the services to everybody who needs them. So I think it's about working smartly, working quite publicly and openly, but also doing some, you know, kind of like behind the scenes work as well. That can be really, really helpful. So again, informal intelligence sharing, informal brainstorming, all of that can help all of us. So just keep the communication channels open.
That's really great. And I think rightfully said, and I know from our G and people aside, we say we've been receiving for so long from you all, and where we can be able to serve you, we try to do that as well. Where we can be able to do something so that you can not have to focus there, we're trying to sort of show that leadership as we move ahead. I think this has been an exciting conversation, and Andy rightfully says we can talk the whole day, mostly because we are friends and
Yes.
we've grown in the industry together, but because our minds, I feel, are working on the, like, there's this thing and that thing and that thing. Like, I'm like, I did ask you about multiplex and dual testing and diagnostic opportunities, but we can talk about that later.
Another time.
But colleagues, this is Andy, an ally, a friend, a person living with HIV just like us, but a leader too, leading in WHO, leading in different spaces, connecting the dots and making sure that everything that serves our community gets to us in the way that we should. And I think this has been an interesting conversation. Thank you so much for agreeing to do it last
Pleasure.
minute.
Real pleasure for us.
It's been a joy to host you in this podcast series.
Thank
Thank you very much.